Good morning, dear friends. The topic of today's lecture is the cerebral hemispheres, structure and function localization of the cerebral cortex, and higher cortical dysfunction. The cerebral cortex is the outer layer of neural tissue of the brain in humans. The right and left cerebral hemispheres are separated by a deep midline sagittal fissure, the longitudinal cerebral fissure. In the depth of the fissure, the corpus callosum connects the hemispheres across the midline. Three surfaces of cortex are distinguished: superior lateral surface of hemisphere, or convex or convexital surface, inferior surface of hemisphere or basis, and medial or internal surface of hemisphere. I want to show this is the superior lateral surface of hemisphere or convex. We can distinguish sulcus rolandi or sulcus centralis, sulcus sylvii or sulcus lateralis, precentral gyrus, postcentral gyrus, the frontal lobe, the parietal lobe, the temporal lobe, and the occipital lobe. This is the upper view. We can distinguish the frontal lobe, the parietal lobe, and the occipital lobe. This is the basis of brain. On this view, we can distinguish the frontal lobe, temporal lobe, and occipital lobe. This is the internal or medial surface of brain. The temporal lobe, parietal lobe, occipital lobe, and frontal lobe are visible. So, in order to increase the surface area of the cerebral cortex maximally, the surface of each cerebral hemisphere is thrown into folds or gyri in English, which are separated from each other by sulci or fissures. The biggest ones separate four lobes, which are named according to the cranial bones under which they lie: the central, parieto-occipital, and the lateral sulci are boundaries used for the division of the cerebral hemisphere into frontal, parietal, temporal, and occipital lobes. Once again, superior lateral or convexital surface of brain, sulcus centralis, sulcus lateralis are visible on this surface, and sulcus parieto-occipitalis, it's only projection. This sulcus is visible only on internal surface of a brain, and we can distinguish four main lobes: the frontal, parietal, occipital, and temporal lobes. Every specific part of the cerebral hemispheres is responsible for a central aspect of function. In normal circumstances, these functions are integrated and the patient operates as a whole. Damage to part of the cortex will result in a characteristic disturbance of function. The scientists who have described the basis of histological and functional differences, the normal cerebral functions on every lobe, and the corresponding cerebral dysfunction were Brodmann, Canadian, and Betts, old Russian scientists. He lived and worked in Kiev in the 19th and beginning of 20th centuries. I want to give a definition of dominant hemisphere. Unilateral brain damage reveals a difference in function between hemispheres. The left hemisphere is dominant in all right-handed people. In left-handed people subjects, the left hemisphere is dominant in the majority, up to 75%. Is the mistake to think that all left-handed people have opposite hemisphere like dominant. No. In left-handed people subject, the left hemisphere is dominant in the majority, up to 75%. The dominant hemisphere, where is it? Is called because all centers of cognitive functions, speech, language-dependent memory, reading, writing, gnosis, and praxis are situated here. What is it, gnosis and praxis? We will describe a little bit later. You see, all cognitive functions are presented in the dominant hemisphere, the left hemisphere in the majority. The first lobe, we are discussing the frontal lobe. Precentral gyrus. This is location of the precentral gyrus, just in front of the sulcus rolandi or sulcus centrale. Motor cortex supplies the contralateral movements of face, arm, leg. Localization of body parts. Legs, superiorly and partially in the medial fishy surface. Arm, in the middle part. Face, tongue, jaw, lips in the inferior part of the precentral gyrus. Tractus corticomuscularis starts from the giant cells of Betts, which lie in the fifth layer of motor cortex, and they are the first or upper motor neurons of this tract here. Do remember, axons of these first order motor neurons go down and make decussation in the border between medulla and spinal cord, and then form descending tract in the contralateral funiculus lateralis and terminates on the impulse terminates on the needed level in the anterior horns, where the second order neurons lie. In case of pathology, central, spastic, mono or hemiplegia or paresis due to upper motor neuron lesion, depending on extent damage. Do you remember clinical features of the upper motor neuron weakness? I want to revise. The first clinical sign, very important for us, for distinguishing process, what are clinical signs of the upper motor neuron weakness. This is spasticity, special type of hypertonicity. Passive movements produce a clasp knife quality, when a doctor can feel resistance only at the beginning of movement, extension or flexion of limbs. You remember, how can we check muscle tone? Passively flex and extend their extremity. In upper limbs, tone of flexors is more than tone of extensors. In lower limbs, tone of extensors is more than flexors one. So, muscle tone hypertonicity is not equal in different groups of muscles and extremities. This results in the spastic posture with the arm and the wrist flexed and the leg extended, Wernicke-Mann posture. This is our patient with pathology of right side of hemisphere and pyramidal tract is affected. The first motor neuron, upper motor neuron, is affected, and this patient has special posture, Wernicke-Mann posture, with a flexed arm and extended leg, and special gait, hemiplegic gait. The leg is extended and the toes forced downwards. When walking, abduction and circumduction at the hip prevent the toes from catching on the ground, forming a semicircle. This is typical picture of patient after stroke with hyperflexion of arm and hyperextension of leg. This is also patient with flexion of arm and extension of leg. Deep latching gait. In paraplegia, do you remember what is it, paraplegia? When both upper extremities or both lower extremities are affected. So in lower paraplegia, when patient has both sides, lower extremities, plegia or paresis due to affection of the upper motor neuron. In paraplegia, spastic paraplegia, strong abduction at the hips can produce a scissor slice posture of the lower limbs. The hips and knees are flexed and adducted with the ankles extended and internally rotated. Upper motor neuron weakness. Hyperreflexia of deep, tendon and periostal reflexes is the second sign of the upper motor neuron weakness. Depressed or absent of superficial reflexes, abdominal or cremasteric. So, hyperreflexia of, for example, triceps, biceps, knee jock, ankle jock, and absence of abdominal reflexes. There are characteristics of their upper motor neuron weakness. Pathological reflexes. The main is plantar response, Babinski reflex. Stretch with a stick or a handle of a hammer along the lateral side of the sole towards the big toe. Note the extension of the big toe. Normally, we can see only flexion of the big toe. This is the picture of Babinski reflex. spontaneous bilateral Babinski sign due to pathology of the upper motor neuron. And clonus applies sudden and sustained flexion to the ankle or knee. Note a few persistent rhythm beaks. It can be observed also while examining knee and ankle jerk. Several jerks instead of one jerk in normal condition. Okay, you see, this is familiar information. I explained all these signs of the upper motor neuron when we discussed pathology of the pyramidal tract. I want to revise and remind to you this information only. Ankle clonus. Support the patient's leg with both the knee and ankle resting in 90-degree flexion. Briskly dorsiflex and partially avert the foot, sustaining the pressure. Do not leave the hand after dorsiflexing. Clonus is felt as repeated beats of dorsiflexion or plantar flexion. And patella clonus is the second type of clonus. Their legs should be extended and relaxed. Examiner grasps their patella between index finger and thumb and executes a sudden, sharp downward thrust, holding downward pressure at the end of the movement. Clonus is felt as a repeated upward and downward movement of the patella. Now, please, new information, because this is information about only cortical part of the corticomuscular tract. In case of irritation, simple partial motor seizures or partial seizures evolving to tonic-clonic convulsions. Movements involve the contralateral face limb. There are Jacksonian motor seizures. The localization of seizures demonstrates the site of tumor or other pathological process.
En voilà une. Oui. Celle-là, elle est très forte. Hein. Elle est très forte. Tu peux pas remettre, maman?
There were Jacksonian motor seizures of left lower limb, and in the left side of this slide,
En voilà une.
you've seen the
Oui.
recording of EEG, electroencephalogram. So, go on. Broca's area in dominant hemisphere. In inferior part of dominant frontal lobe, this is expressive center for speech. In case of pathology, motor or expressive or Broca's aphasia or dysphasia. Comprehension is normal. Speech is non-fluent, hesitant, with repeated syllables. Though the speaker may be quite clear as to what he or she wishes to say and may communicate successfully. For example, touch the table or close your eyes, please, and a patient can understand your command and to perform this command. Comprehension is normal in case of Broca's dysphasia or aphasia. Center of graphia or handwriting in dominant hemisphere in middle frontal gyrus. In case of pathology, handwriting poor, usually is associated with the motor dysphasia. The supplementary motor area just in front of motor cortex, superiorly to Broca's zone, center of contralateral head and eye toning. In case of pathology, paralysis of head and eyes movement to opposite side. Head turns toward diseased hemisphere and eyes look in the same direction. Prefrontal area, the vast part of the frontal lobe anterior to the motor cortex, the pole of the frontal lobe. Functions: personality, initiation, and behavior. In case of pathology, disinhibition, emotional lability, apathy, indifference, poor abstract thought, maybe akinesia, primitive reflexes like grasp pout, gait apraxia, astrasia abasia, Latin terms, astrasia abasia, patient is not able to keep standing and walking, astrasia abasia, and muscle resistance. Very interesting case. One of the most and famous frontal lobe injuries happened to a railroad worker Phineas Gage. Gage survived after a railroad spike impaired a portion of his frontal lobe. Though Gage survived, he lost his eye and much of his personality. Gage's personality dramatically changed, and the once mild-mannered worker struggled to stick to even simple plans. He became aggressive in speech and demeanor and had little impulse control. Much of what he knows about the frontal lobe comes from case reports on Gage. In general, however, damage to the frontal lobe due to a blow to the head, a stroke, growth, and diseases can cause the following symptoms: speech problems, changes in personality, poor coordination, disbalance, difficulties with impulse control, trouble planning or sticking to a schedule, etc. Paracentral lobulus, in middle surface visible, posterior part of superior frontal gyrus. You see, this is internal or medial surface. Is visible. This part is visible only on this part, internal part of frontal lobe. Function: cortical inhibition of bladder and bowel voiding. In case of pathology, incontinence of urine and feces, loss of cortical inhibition. Anatomy of English parietal, Latin parietal lobe. We can see postcentral gyrus, sulcus intraparietalis, and below gyrus supramarginalis and gyrus angularis. Postcentral gyrus. This is the somatosensory cortex. Representation is similar to the motor one. Receives afferent pathways for appreciation of posture, touch, passive movements, that is, of all types of somatic sensation, the deep sensation as well as the superficial sensation. All modalities of sensation are presented. This is cortical center of all modalities. You see, the presentation is similar in somatosensory cortex to the presentation of body parts in motor cortex. In case of pathology, also new information. Our patients can have contralateral anesthesia, all types. But in case of irritation, simple sensory or Jacksonian seizures or partial seizures evolve into tonic-clonic convulsions sometimes. The patient feels paresthesia, tingling in contralateral half of face, arm, leg, according to the localization of tumor or other pathological process. So, if the tumor, for example, is located in the upper part, convexital part of the postcentral gyrus, the patient feels this phenomenon in contralateral leg. If the localization of tumor is in lower part of the postcentral gyrus, the patient can feel this phenomenon in the contralateral face. You see, the localization of paresthesia can help in the localization of the pathological process. Some words about supramarginal and angular giri, or giri in Latin, just behind postcentral gyrus. Here, supramarginal and angular. I want to give a definition of gnosis. Gnosis means recognition. A recognition of some aspect, for example, of subject, of object, of sound, of taste, recognition. Now we are discussing special types of recognition pathology which are typical for the affection of the parietal lobe. The first one are stereognosis in case of supramarginal gyrus pathology. Impairment of appreciation of size, shape, texture, and weight, that is recognizing of objects placed into the hand with closed eyes. For example, coin, pen, key. Another type of agnosia, outer top agnosia, impairment of appreciation of own body image, disorientation in right-left limbs, difficulty in distinguishing fingers. For example, touch your left ear with your right index finger. Patient is not able to perform this task. Anosognosia, impairment of appreciation of own disease or defect, even when densely hemiparetic limbs denies weakness. For example, I remember a patient, old lady with hemiplegia of extremities. She was a bedridden patient with hemiplegia without active movements. But during consultation, she asked, please discharge me from the hospital. I have to take care about my great children. This is the typical example of anosognosia in patient after stroke. Geographical agnosia, disturbance of geographical memory. For example, patient cannot find his bed in ward. One more new term, please. Apraxia. Apraxia. Difficulty in occurring of skilled movements formed during life experience without paralysis, sensory and coordination disorders. Examples: dressing apraxia, difficulty in dressing, for example, getting arm into sleeves, or contractional apraxia, cannot copy geometrical pattern. Difficulty in occurring of skilled movement, please remember. Maybe difficulty in habited movements. For example, we ask our patient to brush the hair, to clean the teeth, to switch up the lamp, to button, etc. Pathology of dominant angular gyrus. Acalculia, disturbance of calculation. Agraphia, disturbance of handwriting. And alexia, disturbance of reading. Okay, we described the frontal type of frontal modality of agraphia some minutes ago, and in that case it was motor disorder, but comprehension was normal. When we say about parietal lobe pathology, their comprehension of letters of text which must be written by this patient is poor. The comprehension is poor when parietal pathology is affected. Their comprehension is normal when frontal pathology is affected. And typical Gerstmann syndrome, in case of angular gyrus pathology, dominant hemisphere stroke syndrome affecting the left parietal lobe in the region of angular gyrus, consisting of 4 components: agraphia or dysgraphia, acalculia or dyscalculia, finger agnosia, and left-right disorientation. Gerstmann syndrome. The temporal lobe. This is the Wernicke center, Wernicke language center, but some authors describe these angulars and Wernicke zone together because they are situated very close in the connecting part of 3 lobes: parietal, occipital, temporal in dominant hemisphere. This is center of auditory speech comprehension. In case of pathology, we can have Wernicke's dysphasia or aphasia, sensory or receptive. Comprehension is impaired. Patient unaware of language problem use many neologisms, non-existent words, maybe paraphrasia, repeated words. The speech is absurd, senseless, as a result of own speech comprehension disturbance, often associated with impaired reading and handwriting. So once again, I want to say, when we have Broca's or frontal aphasia or dysphasia, comprehension is normal. Patient can perform your task. For example, please smile, please blink. In this case, patient has poor comprehension and is not able to perform the simple task, even the simple task, like blink or smile. Amnestic aphasia. The patient cannot name the familiar object, but understands their purpose. For example, pen. This object is to write. What is the name of the object? Oh, I cannot say. Hammer. This object is used by doctors. And other examples. Other symptoms of temporal lobe. Auditory cortex. Location, superior temporal gyrus. But cortical deafness may be only when bilateral lesions, and very rarely, even never, because every cochlear nerve connects with both hemispheres, and so patient can have compensation from healthy side. But in case of irritation by tumor growth, for example, patients can have auditory hallucinations. And vestibular cortex is located here in superior temporal gyrus. And in case of pathology, sometimes maybe cortical temporal ataxia, because there are final parts of vestibular nerves. The temporal lobe pathology can give also memory problems in case of pathology of middle and inferior gyrus. Irritation, hallucinations with déjà vu or jamais vu phenomena. I think you know these French terms. Déjà vu means already seen, the impression that something seen or some situation being experienced for the first time has been previously seen or experienced. And jamais vu, never seen, subjective mental reaction of being in a completely strange environment when in familiar surroundings. Déjà vu and jamais vu. On medial surface and inner surface of brain, we can have the limbic cortex, the inferior and middle portions of the temporal lobe, including hippocampus and parahippocampal gyrus. What are the functions of this limbic system? Special sensation, olfactory zone, taste zone. Olfactory and taste fibers terminate in the uncus, in hippocampal, parahippocampal, and uncus. Disorders, only when bilateral lesions. The same situation. Every olfactory nerve and taste fibers have bicortical bilateral presentation in brain, and very good compensation in case of unilateral pathology. But in case of tumor growth, patients can have irritation of these cells and olfactory or taste hallucinations. And one more sign of this zone pathology. This is center of emotional or affective behavior. In case of pathology, may be aggressive or antisocial behavior, inability to establish new memories. And the fourth zone of the cortex, this is the visual cortex, the occipital lobe. It was said, sulcus parieto occipitalis is well visible on the inner surface and on the projection on the convexital surface of brain or spirolateral surface of brain. This is fissura calcalina in the central and in the upper part of this zone. This is conus, in the lower part, gyrus lingualis. This is anatomy. Okay, and for appreciation of the pathology, we are to revise anatomy of optic nerve and subcortical and cortical centers of vision. The lens sits behind pupil and helps focus light onto retina and reverses objects projected to retina. For example, if, the object is located, like head of this lady, for example, in upper part of visual field, the projection of this object is located in the lower part on retina, and vice versa. If, for example, the object is located in the temporal part of visual field, it's projected on retina in the nasal half of retina, opposite side, due to work of lens. So, the optic nerve is formed by the convergence of axons from the retinal ganglion cells. This cell in turn receives impulses from the photoreceptors of the eye, rods and cones. So rods and cones which receive information, there are photoreceptors, then bipolar cells and ganglion cells, and axon of these cells form the optic nerve. After its formation, the nerve leaves the bony orbit via the optic canal. It enters the cranial cavity, running along the surface of the middle cranial fossa in close proximity to the pituitary gland, where the chiasm, optic chiasm, is situated. At the chiasm, fibers from the nasal medial half of each retina cross over to the contralateral optic tract, while fibers from the temporal lateral halves remains ipsilateral. After optic chiasm, we name optic tract in front of the chiasm optic nerve, and, for example, left optic nerve receive information from medial and lateral halves of the same left retina and from opposite vision fields. But after partial decussation only of middle halves of fibers in chiasm, left optic tract contains fibers from the left temporal lateral retina and the right nasal medial retina, and right optic tract contains fibers from the right temporal retina and the left nasal retina. As a result, each optic tract travels to its corresponding cerebral hemisphere. To reach the lateral geniculate nucleus, a relay system located in the thalamus, the fibers synapse here. Axons from the lateral genicular nucleus carry visual information via a pathway known as the optic radiation. The pathway itself can be divided into upper optic radiation, carries fibers from the superior retinal quadrants corresponding to the inferior visual fields quadrants. It travels through the parietal lobe to reach the visual cortex. And lower optic radiation carries fibers from the inferior retinal quadrants corresponding to the superior visual field quadrants. It travels through the temporal lobe via a pathway known as Mayer's loop to reach the visual cortex. So, information passes to the cortex and striate cortex just around the Fischer calcarina. This is primary visual cortex, visual reception. Above and below this lies parastriate cortex, association visual cortex. In case of pathology, for example, of primary visual cortex, maybe only photopsias like flashes, for example, and lights. In case of irritation of association visual cortex, patients can feel hallucinations like pictures, movies, so on. Finally, summary of this information. Both hemispheres of the brain contain a visual cortex. The visual cortex in the left hemisphere receives signals from the right visual field, and the visual cortex in the right hemisphere receives signals from the left visual field. So, due to incomplete decussation in chiasm, our cortex receives information from the contralateral side of visual field, from both eyes. Some words about semiotics. Terms: hemianopia or hemianopsia in some words, in some books, is a loss of vision or blindness in half the vision field. Two modalities, two types of hemianopia: homonymous, left side, right side, and heteronymous, binasal, bitemporal. Where is it? Homonymous hemianopia is the loss of half of the visual field on the same side in both eyes. Left side hemianopia, right side hemianopia. A heteronymous hemianopia is the loss of half of the visual field on different sides in both eyes. It's separated into two categories: binasal hemianopia and bitemporal hemianopia, visual fields. Quadrantopia, quadrantopsia, or quadrantic hemianopia is a decreased vision or blindness in 1/4 of the vision field. And contralateral quadrantopia occurs when damage of only cuneus or gyrus lingualis, or when optic radiation damage. Left quadrant, superior hemianopia. Left quadrant, inferior hemianopia on these pictures. So, let's analyze different types of sight pathology, visual pathology. Different levels of pathology. For example, when this nerve is affected, the optic nerve is affected, what can our patient have? Total blindness of the same eye, in this case right eye, due to complete lesion of right optic nerve. So, this eye is blind. Easy. In case of chiasm, in this case, 2, the central crossed part of chiasm is affected. In this case, go to this eye, this half, inner half of retina, and opposite temporal half of visual field is affected. Go to the right side, inner half of retina, and opposite temporal half of visual field is affected. So our patient can have bipolar hemianopia due to midline chiasmal lesion. Due to, for example, pathology, tumor of pituitary gland. In this case, uncrossed part, lateral part of chiasm is affected by aneurysm, for example. Go to the eyeball, to the retina, this half, and then to the visual field, inner part, nasal part of visual field is affected. In this case, right nasal hemianopia due to lesion involving right perichiasmal area. So please remember, patients can have heteronymous hemianopia only in case of chiasma pathology. Heteronymous hemianopia only in case of chiasma pathology. Crossed inner part, bipolar, and uncrossed outer halves of chiasm, binasal or one side nasal hemianopia. Go on. We know after chiasm it is optic tract. In this case, left, right, in right side, in this case right side, right optic tract is affected. What can our patient have? Go to this side. And contralateral, left contralateral side hemianopia. Go here, opposite, also left contralateral visual field hemianopia. So in this case we have contralateral, in this case left side, homonymous you see to right or to left, hemianopia. Why? Because this tract, in this case right side, right optic tract, and other structure, radiator and cortex, after this point, receive information from ipsilateral halves of retina of both eyes and contralateral visual fields. So in case of pathology of tract, nucleus geniculatus, radiatio, cortex on this right side, we can have only contralateral homonymous hemianopia or quadrantopia. For example, this example, partial damage of radiatio optica. Number 5. Left homonymous inferior quadrantopia due to involvement on floor right optic radiation. We reverse the image. Number 6. Left homonymous superior quadrantopia due to involvement of upper right optic radiation. And in case of total pathology of occipital lobe, left homonymous hemianopia due to lesion of right occipital lobe. Thank you for your attention.